Hello and welcome. My name's Tim Poe. I'm Director of Telehealth with the UNC Cancer Network. Thank you so much for being with us today, January 10th, 2018, for our UNC Cancer Network RN and Allied Health Lecture. A few preliminaries and then we'll get started. If you're having any trouble at all, any technical difficulties, please go ahead and email us at unccn@unc.edu, or better yet, call us at 919-445-1000. Again, 919-445-1000. We have people, technical experts standing by who will help you if there is any problem at all that you are experiencing. I will say that there's something a little quirky going on with the system that we use to connect the video conferencing units today. And so we've had some that have dropped off, and when we reconnect them, we're finding that they are not muted. So if for any reason you notice that you disconnect and then we connect you back in, please make sure that you're muted. And we just lost a connection here as well. I apologize. So we'll try to get that restored as quickly as possible. Bear with me for just a moment. There we go. We've got our slides back. As I mentioned, it's the beginning of a new year, and so we are experiencing a few things. I think we'll get through them, and we should have a great lecture today in spite of that. We're on the web at unccn.org. You can find us there. Let me go ahead and adjust my camera. There we go. We are going to start in just a moment with a poll everywhere poll. And the poll question is, according to the journal Nature, Fluorouracil has a fluorine atom attached to the blank of uracil pyrimidine base. So we want you to take a look at this and think about what answer, this is anonymous, but what answer you would choose. 2 position, 3 position, 4 position, or 5 position. A would be 2 position, B 3 position, C 4 position, or D 5 position. The way Poll Everywhere works is you can either go to a web browser and go pollev.com/UNCCN, and you'll see our questions there, as both the question at the beginning and then the place for submitting your questions at the end. A lot of our listeners, what they tend to do is use their phones. Any phone that has texting capabilities will work. And you text to the number 22333, the letters UNCCN. You only need to do that one time. And that you'll get a little message back that says join, and then you can go ahead and respond to this first poll question. So again, if you think the answer is 2 position, you'll put in A, 3 position B, 4 position C, or 5 position D. Good thing about joining Poll Everywhere is then you'll be ready to submit your questions at the end of Dr. Faso's presentation. All right, so with that in mind, we are so glad to have Dr. Aimee Faso here with us today. Dr. Faso, welcome. Thank you so much for being with us.
Thanks for having me.
Absolutely. Introduction, Dr. Aimee Faso is a clinical pharmacist practitioner at UNC hospitals and clinics and an adjunct instructor with the Division of Pharmacy Practice and Experimental Education experiential education in the UNC Eshelman School of Pharmacy. Dr. Faso received her PharmD from the University of Florida and completed her pharmacy practice residency at Dartmouth-Hitchcock Medical Center. She is a board-certified oncology pharmacist, and her practice interests focus on patient education and supportive care of cancer patients. Come hear Dr. Faso speak all about her experiences, pharmacy interests, and day-to-day life as a pharmacist at the UNC Cancer Hospital.
Mm-hmm.
Great.
Thank you.
Well, thank you. Tell us what led to your interest in pharmacy.
Well, actually, when I was an undergraduate, I was studying psychology.
Okay.
And that was where I started to study drugs that we use for things like depression, anxiety.
Great.
And I started to get interested in those drugs. And that really kind of started the whole path to eventually becoming a pharmacist.
Gotcha. Gotcha. Well, we're glad that happened, and we're glad to have you here today. Let's see how our how folks did with the poll. Nobody's going for 4 position, and it looks like we're running neck and neck with 3 and 5. What would the actual answer be?
So the answer is D.
All right.
So you'll hear the other name of fluorouracil as 5, fluorouracil.
Okay.
And hence the 5
The
position.
5 position. Okay, very good. Well, without further, disclosure statement, we have to read that. So this activity is planned and implemented under the sole supervision of Thomas Shea, MD, the course director in association with the Office of Continuing Professional Development. Thomas Shea, MD, consults for Spectrum Pharma and receives research support from Millennium, Otsuka, GSK, BMS, Novartis, and Seattle Genetics. CPD staff have no financial relationships with commercial interests. Our speaker, Aimee Faso, PharmMD, BCOP, CPP, has no conflict of interest relevant to this presentation. And without further ado, we will give you the controls, and you're good to go with Fluorouracil 5FU toxicities and strategies for management.
Okay, thank you
All right.
so much.
Thank you.
So I'm so pleased to be here today, and I want to go over first what are my objectives for the presentation. Well, first I would like to identify and describe the hematological, dermatological, and gastrointestinal toxicities of 5-fluorouracil. Secondly, I will describe the methods to manage these toxicities with patients who are receiving 5-fluorouracil. And thirdly, describe the use of uridine triacetate in patients who exhibit 5-fluorouracil overdose or patients who exhibit severe adverse reactions from 5-fluorouracil. So the first thing I'd like to do is just talk about the history of 5-fluorouracil. This is a cytotoxic drug that has been used for a very long time. It's been more than 40 years, used to treat various cancers, including breast cancers and most notably colon cancers. So it was in the 1950s, actually, that Heidelberger and his colleagues were studying the metabolism of hepatoma cells in rats, or hepatocellular liver cells that are cancerous. And what this group found was that these cells actually had a greater uptake of uracil compared to normal cells. So Heidelberger and his colleagues decided that they would attach a fluorine atom to the 5 position of uracil, and hence the name 5-fluorouracil, as the question asked in the beginning. And what this did is that having a fluorine in this particular position, that actually is a much tighter bond than the normal bond. It allows fluorouracil or 5-fluorouracil to act similarly biochemically, but it affects the functionality. So this is really the first example of targeted therapy. And it was really in the 1970s that the administration of 5-fluorouracil by continuous infusion was found to have improved response rates for the treatment of anal and colon cancers. And then in the 1980s, the infusional administration of this drug was used much more widely. And that was due to the availability of central venous access to patients as well as to pumps for outpatient administration. So let's look a little bit at the mechanism of 5-fluorouracil, and for the remaining of the talk, I will refer to it by its abbreviation, 5FU. And like I have mentioned, it is a synthetic analog of uracil, which is a pyrimidine base. And in order to 5-fluorouracil to work, it needs to actually be metabolized to active metabolites in the body. So there is a diagram illustrating it being converted to these active metabolites. And there's multiple active metabolites. And actually, once it's converted to one of these metabolites, FUTP, and that's here in the diagram, this gets incorporated into RNA. When it's incorporated into RNA, it actually prevents RNA synthesis and therefore prevents protein synthesis. The other way that it can work, sorry about that. The other way it can work is converted to a different active metabolite that gets incorporated into DNA, and actually, because of that fluorine, it actually causes DNA strand breaks. And then finally, the third main mechanism is you can see here on the right-hand side, one of the active metabolites can inhibit a very important enzyme, thymidylate synthetase. And inhibiting this enzyme actually results in DNA damage. So these are the 3 main mechanisms. One of the interesting things is how 5FU is given can determine which mechanism might be the most active. So for example, if 5FU is given by bolus, then actually you'll see more incorporation of 5FU into RNA. If it's given by a continuous infusion, then you actually see more inhibition of this thymidylate synthetase. And importantly, 5-FU works more on proliferating cells rather than resting cells. So many regimens that use 5-FU also utilize leucovorin, and this is a drug that's given prior to leucovorin, and it's actually folinic acid, which is an active metabolite of folic acid. So looking on the diagram on the right, you can see I have circled here LV, that's the abbreviation that they're using for leucovorin. What it does is it actually stabilizes the bond of this active metabolite of fluorouracil to that enzyme, thymidylate synthetase. And what that does is it actually decreases the production of thymidylate, which is what that enzyme produces, and therefore you actually enhance the activity of 5-fluorouracil. So for those of you who are familiar with using leucovorin with the chemotherapy drug methotrexate, with methotrexate, leucovorin is considered a rescue, so therefore it can actually reduce toxicity with methotrexate. But it actually has a very different action when it's administered with 5-FU. So it actually enhances the activity of 5-FU and can also enhance toxicity. So for the administration of 5-FU, you can see that there's multiple ways that it can be given. And as I mentioned previously, it can be administered intravenously, and that can be by bolus or by continuous infusion. It can also be given orally, and that is what we call a prodrug, and it's known as capecitabine or Xeloda. And when someone takes capecitabine, it gets converted by the body to 5-FU, and it can also be given topically. So for this talk, we're going to concentrate on intravenous administration of 5-FU. And there's 5-FU intravenously can be given by many different regimens and a variety of schedules. So on this slide, I have just an example of 4 different regimens. And as you can see, there can be a lot of variability from one regimen to the next. The first 3, the Roswell Park, the Mayo Clinic, and the modified FOLFOX6, these are regimens that are given for colon cancer. The last one, CMF, is one that's given for breast cancer. So some things I wanted you to note is that the Roswell Park, the Mayo Clinic, and the last one, the CMF, in those regimens, 5-FU is given by bolus. Whereas in the modified FOLFOX6, it's given by a bolus followed by a continuous infusion of 5-FU over 46 hours. Also, Roswell Park, Mayo Clinic, and FOLFOX6 also, they utilize leucovorin, like we had mentioned can be done, but in CMF, leucovorin is not given. So these are just actually a small example of different regimens, and there's many, many more that are utilized. The other thing to notice is that 5-FU can be combined with many different agents. So, for example, in FOLFOX6, it can be combined with oxaliplatin, CMF combined with cyclophosphamide and methotrexate. So we're going to focus on some potential toxicities of 5-FU. So we're going to focus particularly on hematological, the dermatological, and gastrointestinal toxicities. There are potential toxicities that are cardiovascular or ophthalmic, but we're not going to concentrate on those today. And the toxicities that patients can experience depend on the regimen and how the 5-FU is administered. So first, let's look at the hematological toxicities. So bone marrow suppression is a possible toxicity of 5-FU, and it is particularly neutropenia that patients can experience. Thrombocytopenia and anemia are possible, but at a much lower incidence. Neutropenia, if patients are not properly managed, can be severe or fatal. And neutrophil naters can occur anywhere from 9 to 14 days after 5-FU is administered. So I just wanted to go over the grading of neutropenia and just to help us later when we're talking about management of patients who have neutropenia. And I'm using the common terminology criteria for adverse events, or CTCAE, that is used by the National Cancer Institute. So the higher the grade, the worse the toxicity. So for grade 1, this is an absolute neutrophil count, or ANC, of up to 1,500. Grade 2 is an ANC of 1,000 to 1,500. Grade 3 is 500 to 1,000, and then grade 4 is an ANC of less than 500. So looking at the hematological toxicities, neutropenia actually occurs more when 5-FU is given by a bolus infusion compared to a continuous infusion. And in the late 90s, there was a meta-analysis that looked at 6 randomized trials of about 1,200 patients. And these were patients who were receiving various regimens, but all for advanced colorectal cancer. When they looked at the toxicities that these patients experienced, they found that neutropenia was the primary hematological toxicity. And anemia and thrombocytopenia actually only accounted for about less than 5% of the patients. And in those results, 4% of the patients who received the regimen with a continuous infusion had grade 3 or 4 neutropenia, as opposed to 31% of the patients who had a bolus 5-FU had grade 3 or 4 neutropenia. And this was statistically significant. So indicating that bolus 5-FU results in greater neutropenia. Also to note was that patients who had a poor performance status were also at higher risk for this toxicity. So how do you manage patients with neutropenia? Well, first is proper management. So monitoring CBC with DIF is critical, and that should be done at least each cycle or at least weekly, depending on the regimen that they're being administered. And if you look at the package insert of 5-FU, they recommend to withhold 5-FU once patients have a grade 4 toxicity. But I must say that in my groups, we tend to hold more for grade 3 than grade 4 toxicity of neutropenia. And then once the neutropenia resolves or at least goes to grade 1, the dose can be resumed. Now, one thing that in my groups that we do actually is patients who are receiving regimens that have a combination of a bolus 5-FU and a continuous infusion 5-FU, and some examples of this are FOLFOX or FOLFIRI. Then actually if patients do experience neutropenia, we actually discontinue the bolus and then resume the continuous infusion at full dose. And this actually usually results in less neutropenia than if you had both types of both doses. Okay, so now what I'm going to do is move on to gastrointestinal toxicities. And the first one that we're going to focus on is oral mucositis. So oral mucositis being inflammatory or ulcerative lesions, and these can occur anywhere within the mouth or throat, so the pharyngeal, laryngeal, or the esophageal regions. And the incidence can vary widely depending on the regimen. So in patients who are getting just 5-FU alone, the incidence has been reported up to 22%. But combined with other chemotherapy, you can see that report of incidence goes up greatly, so that's about 74%. And like neutropenia, the incidence is greater with bolus 5-FU compared to continuous infusion 5-FU. And interestingly, a study in 2000 found that women were more likely to develop mucositis than men. So patients can start to develop mucositis within a week after starting 5-FU. And patients might notice redness. They may also experience burning. And if this side effect progresses, it can be white or painful patches, and even a severe form would be epithelial sloughing. Usually, once 5-FU is stopped, these ulcerations can usually heal within 14 days. So the pathophysiology of how 5-FU causes mucositis is actually complex, and I'm not going to go into the details here, but it is actually a 5-stage process that leads to these painful ulcerations. And having mucositis can really affect daily function, and when people have pain in their mouth, it can affect their oral intake and therefore affect their overall nutrition, and that is affecting their quality of life. And also, having mucositis can put patients at more of an infection risk, can cause dose delays or dose disruptions. So looking at the grading, you can see that grade 1 is patients are asymptomatic or have mild symptoms. Grade 2 is moderate pain that can where they need to modify their diet. Grade 3 actually is severe pain interfering with oral intake, and grade 4 is life-threatening. So the best way to treat oral mucositis is actually to do what you can to prevent it in the first place. And there are guidelines available that discuss what are the best options. So basic good oral hygiene is recommended, and this should be offered to patients who are receiving 5-FU. So the recommendation is to use a salt and/or baking soda solution, and that should be done at least 3 times per day. So I usually recommend to patients after they eat or even at bedtime to make sure that they rinse and spit out a salt or baking soda mouth rinse. Also, we recommend to avoid alcohol-based mouth rinses. This is because alcohol usually dries the mouth and actually could make them more at risk for mucositis. Brushing the teeth and keeping the mouth clean with a soft toothbrush is also recommended. And also just basic oral exams, so going to the dentist, can also be very helpful prior to starting the chemotherapy. Now, there's been many drugs that have been tested in order to prevent oral mucositis with 5-FU and other chemotherapy agents, and there really has not been a particular drug that's been found to have any benefit. But one option that you can offer to patients is actually oral cryotherapy for patients who are receiving bolus 5-FU. And the current guidelines do recommend to swish ice chips for about 30 minutes while and after the administration of a bolus 5-FU injection. And there was a study done in 2005 that they looked at 40 different patients. They had them hold ice in their mouth at the beginning of the bolus injection and until 10 minutes after the infusion. And they did the cryotherapy at random cycles. And what they found was that the mucositis developed in just under 7% of cycles when patients held ice in their mouth. And without this cryotherapy, then the mucositis developed in almost 39%. So that was a huge reduction in the development of mucositis with the bolus 5-FU injection. It's believed to work because actually the ice in the mouth causes vasoconstriction, which reduces blood flow to the mouth and therefore reduces the amount of 5-FU that gets to the mucosa. And since it was found to be statistically significant, it is recommended. I will say, however, that if patients are getting oxaliplatin along with their 5-FU, so this is a common combination, then you cannot offer oral cryotherapy. And the reason why is because one of the side effects of oxaliplatin is pain from cold. So patients who would hold ice in their mouth after getting oxaliplatin would experience pain, so this is not an option for them. So for patients who have mild oral mucositis, then to treat them, you can offer oral care, and I do recommend for patients to continue those salt and baking soda mouth rinses. And for some patients, if they just increase the number of salt or baking soda mouth rinses once they start to notice a sore here and there, sometimes that often keeps it stable or even reduces the number of sores that they have. They should continue to keep their mouth clean, but to do it with a soft toothbrush. Also, you should recommend dietary modifications, so avoiding foods that could be problematic. So acidic foods, salty foods, and particularly dry foods like crackers or potato chips. Now, for some patients, these changes won't be enough, and you'll need to offer analgesics. So the first line that you can offer is topical. And so there are mouthwashes that we call magic mouthwash, and these can be utilized to cause for comfort. So there's lots of different combinations that can be used for magic mouthwash, and they can use anything containing Benadryl, Maalox, or nystatin, but the one thing that they all have in common is that they utilize viscous lidocaine. So no mouthwash combination has been found superior to another, so it's really based on the prescriber or the patient preference. So the mouthwashes do provide comfort. They help patients to be able to improve their oral intake, so they are effective, but unfortunately they do have a short duration of action. So for patients where a magic mouthwash isn't sufficient, you may have to offer systemic analgesics. So first line would be an NSAID. If patients have severe pain, an NSAID may not be adequate, and in that case you would have to offer oral or parenteral opiates. So if patients develop grade 3 or grade 4 mucositis, you would want to hold the 5-FU, and then once their side effect resolves, then you can start 5-FU again at a reduced dose. Okay, so the next gastrointestinal toxicity I'd like to go over is diarrhea. So how 5-FU causes diarrhea is actually it damages intestinal stem cells within the crypts of the intestine. And by damaging these cells, it leads to great fluid secretions into the lumen of the intestine and therefore leading to diarrhea. So let's look at the grading of diarrhea. So grade 1 is an increase of less than 4 stools per day over baseline, or if they have an ostomy, it's a mild increase in their ostomy output. Grade 2 is an increase of 4 to 6 stools per day, or a moderate increase in ostomy output. Grade 3 is 7 or more stools per day, or a severe increase in ostomy output. And as you can guess, this would really limit patients' self-care and activities of daily living. And then finally, grade 4 is life-threatening. So diarrhea is definitely a common side effect from 5-FU. All grades has been reported in as much as 72% of patients, really just depending on the specific regimen. And grade 3 and grade 4 diarrhea has been reported in up to 30% of patients depending on their regimen. And like the previous toxicities that I've mentioned, the higher incidence is seen with bolus 5-FU compared to the continuous infusion 5-FU. And also, when used with leucovorin, the incidence of diarrhea increases as well. So in the table below, I do have some reported incidences of grade 3 and grade 4 diarrhea with various regimens. And as you can see, 5-FU with a continuous infusion or CIV is the least likely to cause diarrhea, whereas the bolus infusions tend to cause more. So for patients who develop diarrhea, let's talk about the management. And the first thing to do is just to obtain a good history. So asking the patient about the onset of their diarrhea, looking at the duration. It's important to ask about the number of stools to help you grade the diarrhea, and also the composition of their stools. Also asking the patient what other medications they're on to see if they have other agents that can cause diarrhea. And finally, also asking about their diet to help identify foods that might make their diarrhea worse as well. If patients have more moderate to severe diarrhea, then it's important to assess for dehydration, infection, or bowel obstruction. And finally, for some of patients, especially with more moderate to severe diarrhea, you'll need to rule out other causes as well, such as Clostridium difficile. So for patients who have mild diarrhea, then actually non-pharmacological management may be just enough. And the first thing is to avoid foods that could aggravate their diarrhea. So instructing patients to avoid dairy, caffeine, high fiber or fat foods, or spicy foods can be helpful to reduce diarrhea. Encourage patients to drink clear fluids, and of course that should be all patients who have any grade of diarrhea. And also eating frequent small meals can be more helpful for diarrhea than eating large intermittent meals throughout the day. And it is helpful to recommend the brat diet because this is a diet that doesn't particularly stimulate a stool. So the brat diet meaning bananas, rice, applesauce, and toast. And what I like to do is also to ensure that patients have stopped their laxatives and stool softeners, because obviously these can worsen their diarrhea. And sometimes patients just get in the habit of taking these medications and forget to stop them. So for patients who have mild, moderate, or more severe diarrhea then that is not managed with non-pharmacological treatments, then the first line would be to use the medication loperamide. Loperamide is an over-the-counter drug that's available at any drugstore, also known as Imodium. And this is actually an opiate that acts directly on the smooth wall of the intestinal wall and decreases intestinal motility. It has little or no systemic absorption, and loperamide has a rapid onset of action, so patients can see a decrease in their stools within 60 minutes of the first dose. And this drug has been found to be very effective to reduce incontinence as well as bowel movement frequency. So for patients who have more mild to moderate diarrhea, the standard dose could be adequate to treat their diarrhea. And this is actually the directions that are on the box at the drugstore. And that is you start with 4 milligrams initially, and then you take 2 milligrams after each subsequent loose stool, or you can take 2 milligrams every 4 hours. But for patients who have more severe diarrhea, the standard dose won't be sufficient. And that's when we recommend aggressive dosing. And that's actually 4 milligrams initially, and then 2 milligrams every 2 hours. Or if they're at nighttime, you can go to 4 milligrams every 4 hours. For patients who have severe diarrhea and need the aggressive dose of loperamide, I do tell them that they may exceed the maximum dose recommended on the box at of the Imodium. So the maximum dose is on the box as 16 milligrams per day. I tell patients, as long as other things have been ruled out, such as C. diff, that they can ignore that maximum dose. So for patients who don't respond adequately to loperamide, you may need to go to second-line agents. So the first agent that we usually use is diphenoxylate with atropine, also known as Lomotil. And this is given as 5 milligrams every 6 hours. If this is inadequate, then tincture of opium, it can also be offered, and this is 6 milligrams every 4 to 6 hours. Now I will say in some of our patients, what we do find helpful is to actually alternate loperamide and the Lomotil so that they take one and then followed by the other and alternate throughout the day. Now, occasionally with patients with severe diarrhea, they may not respond to these oral agents or have an inadequate response, and in that case, they need to be offered octreotide. And this is a subcutaneous injection where you give 100 or 150 micrograms subcutaneously. It's administered 3 times a day, and then you have to titrate to response. So for patients who have grade 3 or grade 4 diarrhea with 5-FU, you need to withhold therapy. And then once their diarrhea resolves, you can initiate the 5-FU, but at a reduced dose. So now what we'll do is move on to the dermatological toxicities, and we're going to focus today on hand-foot syndrome. So hand-foot syndrome, it's also known as palmar-plantar erythrodysesthesia, but I'm going to refer to it as hand-foot syndrome today. When this starts, hand-foot syndrome, patients may notice a tingling sensation on the palms or soles of their feet, or oftentimes they may notice a red rash on their hands and feet with some possible edema. And typically when patients start to present this, it'll be on both hands or both feet, but they can have any combination of hands and feet. They may have only their hands, only their feet, or both hands and feet. This side effect can progress so that they can get skin scaling. Some patients can develop to blisters or skin desquamation. And as you can imagine, this side effect can impair activities because it can be painful, and this can affect them from doing their day-to-day things. So if they have hand-foot syndrome on their hands, it can affect daily tasks like grasping. If they have it on their feet, it can actually impair their walking. Now the onset of when this can occur is actually very wide, so anywhere from 3 days to 10 months, and that's due to the wide number of ways that 5-FU is given. So looking at the grading, grade 1 hand-foot syndrome is minimal skin change and importantly without pain. Grade 2 is when patients start to have skin changes with pain. And finally, grade 3 is severe skin changes. And with hand-foot syndrome, there is no grade 4. So the pathophysiology is really not well understood. There's multiple proposed mechanisms on how 5-FU causes this side effect. One of them is, the thought is that 5-FU actually directly affects the eccrine glands or sweat glands that are in the hands and feet. And since these sweat glands are in higher density in the palms and soles of the feet, it's thought that allows more 5-FU to get to the palms or soles of the feet and therefore direct its toxic effects. Another proposal is that 5-FU affects the epidermal basal cells, and these are highly proliferating cells that are located in the palms and soles of the feet. So the thought is, since they are highly proliferative and 5-FU tends to have more effect on proliferative cells, that these particular cells are more sensitive to this side effect. Now, unlike all the other side effects that I've talked about, the incidence is higher with a continuous infusion of 5-FU. And majority of hand-foot syndrome is actually described with capecitabine. So this is that drug that I was talking about that's given orally that is converted in the body to 5-FU. And the reason why is the oral capecitabine more mimics a continuous infusion of IV 5-FU, and therefore that's why this is a greater risk with the oral 5-FU compared to bolus. So that meta-analysis that I had described before, where it looked at 6 randomized trials with just over 1,200 patients, when they looked at this particular toxicity, they found that 34% of patients who received a regimen with continuous infusion of 5-FU had hand-foot syndrome. That's compared to 13% of patients who had the bolus. So again, bolus infusions, unlike with hand-foot syndrome, is less likely to cause this side effect compared to the other toxicities that we mentioned. Now, older patients and women in this particular meta-analysis were found to be actually at higher risk for hand-foot syndrome. So the best thing to do is, again, to treat hand-foot syndrome is to do the best to prevent it. So recommending of lotions is actually the best thing to do. And actually a urea 10% cream, which is available over the counter, should be recommended to use prophylactically. So patients should apply it to their hands and feet up to 3 times per day. So keeping hands well moisturized has been shown to reduce the incidence, particularly in patients who take capecitabine, but this would apply to infusional 5-FU as well. Also importantly is to reduce friction. What we find, especially in the clinic, is that patients who have more friction on their hands and feet are more likely to develop or to worsen hand-foot syndrome. And so what I mean by friction is anything that causes rubbing on the hands and feet. So for example, I find that people who use hand tools actually usually develop that hand-foot syndrome in their hands. People who wear shoes that don't fit well, where those shoes rub, can actually cause the hand-foot syndrome. So I do recommend to patients to do the best they can to reduce friction. So wearing shoes that fit well is one thing. When they're at home, just wear nice comfortable socks. And trying to reduce the friction in their hands, which can be challenging, using gloves may be helpful here. For treatment, we actually continue to have, we tell patients to continue lotions. Sometimes we actually change to a urea cream that's 30% or 40%, but these are available only by prescription. So at higher concentrations can be very helpful for patients. Also, they should continue to keep friction minimal by wearing comfortable shoes, for example, or reducing the friction on their hands. But really with hand-foot syndrome, the only way to resolve the symptom is to actually stop the 5-FU. And usually this side effect can start to resolve within a week of discontinuing 5-FU. So once you discontinue the 5-FU and their symptoms have resolved, you can initiate the 5-FU, but at a reduced dose. So we've talked about management of some of the most common toxicities with 5-fluorouracil, but now what I'd like to do is talk about uridine triacetate. So what to do in patients who present with life-threatening toxicities. So uridine triacetate, with the brand name of Vistagard, was approved by the FDA in September of 2015. And this drug is indicated for the emergent treatment of adults or pediatric patients following a 5-FU or capecitabine overdose, or in patients who exhibit early onset severe or life-threatening toxicity, such as cardiac or CNS toxicities, or early onset unusually severe adverse reactions, and that can include gastrointestinal or neutropenia, within 96 hours following the end of 5-FU or capecitabine administration. So importantly, this medication is recommended for the treatment of emergent cases, not for non-emergent adverse effects. So let's just briefly look how this drug works. So I had mentioned at the beginning of the presentation that 5-FU is converted to an active metabolite. And I just want to point out, so the active metabolite of FUTP is incorporated into RNA to cause that damage of the RNA. So the drug uridine triacetate is converted to uridine, and actually what uridine does is, as the arrow is showing, is that it competes with the FUTP, and actually it outcompetes FUTP in order to prevent FUTP from getting into the RNA, and therefore you can reduce the severity of the toxicity. So how it's dosed in adults, it's 10 grams, which is 1 packet, orally every 6 hours for 20 doses. For pediatrics, it's 6.2 grams per meter squared, or up to 10 grams per dose, and that's also every 6 hours for 20 doses. For patients who have their symptoms resolved, then it is encouraged that they complete all 20 doses. So these packets are mixed with 3 to 4 ounces of soft food, such as applesauce, pudding, or yogurt. And this packet can be administered via an NG or G tube. So the FDA approved this drug based on the combination of 2 single arms. So what they looked at these open label trials was patients who experienced a 5-FU or capecitabine overdose, and they presented with severe toxicities. So these patients could have either had an overdose, just meaning a higher than prescribed dose of 5-FU, or the infusion rate was greater than expected. So in other words, if they had a pump failure and they received the required dose but a much shorter time. And they looked at the primary outcome of survival at 30 days and the resumption of chemotherapy if that was prior to 30 days. So these 2 single-arm open-label trials included 135 patients who received the drug. Of those, 112 patients had a 5-FU overdose. So most of them, 94%, was because of infusion rate overdose, so in other words, pump failures. 4% had a too high of dose of 5-FU, and 3% of those patients had both. When they looked at the primary outcome, they saw 96% of those patients survived or were able to resume chemotherapy within 30 days. And unfortunately, 4% of those patients died. So only 2 of those patients weren't able to take all of those 20 doses, and that was because of intolerance due to nausea, vomiting, and diarrhea. So they compared the results of those 2 open label trials with a retrospective study that looked at 25 patients who did not receive uridine triacetate but after overdosing on 5-FU. And of those 25 patients, they found that 84% of those patients died. So this is a medication that can be given for emergent use for patients who have severe toxicities or potential for severe toxicities. Well, one thing I just want to let you know is that it is a drug that has a limited distribution. And what that means is that you can't get it at any regular pharmacy. There is a specific way that the medication has to be ordered. So for patients who are inpatient, it has to be ordered directly from the manufacturer, and it's distributed specifically through Cardinal Health. But for outpatients, you also have to order it from the manufacturer, and it actually has to come from a specialty pharmacy. So that specialty pharmacy is called Biologic Specialty Pharmacy. They ship medications overnight around the nation, but they happen to be located here in Cary, North Carolina. Or it could be distributed through Cardinal Health as well. Patients who are using an outpatient can be enrolled into the company's case management program, which helps with transition of care and also with adherence with the patients. So it is a little bit different distribution of this medication, so it does, you do have to work quickly to call the manufacturer in order to get the medication. So just in summary, I just want to say that 5-FU is a widely used cytotoxic agent. It's used in many different regimens. Neutropenia, oral mucositis, and diarrhea are potential toxicities, and they're more likely to be caused with bolus injections of 5-FU. Hand-foot syndrome, on the other hand, is a common side effect, but it occurs more often with continuous infusion 5-FU. And these toxicities can be managed with appropriate patient assessment and dose reductions as needed. And we do now have uridine triacetate available for patients who do exhibit severe toxicities following a 5-FU overdose. So any questions?
All right. And let's see, I'll advance this so we can go ahead and allow our users to, our audience to go ahead and submit those questions right on Poll Everywhere. So if you already joined earlier, got that little join message back, or went online, you're all set. Otherwise, text to the number 22333, the letters UNCCN, just once. You'll get a message back, join, and then you can submit your question. This is fascinating. I've got plenty of questions, so I hope you get yours in soon, because I know I've got several. Let me start with the cryotherapy, and you mentioned that for the oral symptoms. We know with Taxol that there are studies coming out showing that cryotherapy can reduce symptoms of peripheral neuropathy.
Right.
Are we seeing anything similar? Have studies been done with IV administration of 5-FU and using similar cryotherapy strategies to reduce the hand-foot syndrome for patients there?
So that we haven't seen that for hand-foot syndrome, and part of that is because of the way the continuous infusion of 5-FU is given.
Okay.
So, for example, a common regimen, it's given over 46 hours.
Oh my gosh! So you don't have that narrow 30-minute window to work with.
Right. So patients wouldn't be able to keep ice on
Understood.
their hands long enough.
Okay. All right. Well, that's interesting. And then in terms of the capecitabine, Xeloda comparisons versus the IV or bolus, or for most of the symptoms here, are those pretty applicable to all of those, whether administered orally or the bolus or IV?
Yes, the side effects are applicable to both the oral and IV.
Okay.
It's just that the incidence changes depending on how it's given.
Right.
But we do have patients who can have severe diarrhea with capecitabine. That's not common, but it certainly is possible.
Right, right. And as you mentioned, that C. diff is something to look for as well in certain situations.
Absolutely. You'd want to rule that out so you can treat them appropriately.
Right,
Yes.
very good. Let's see. I know I had a couple of others, and then I'm sure we'll have some questions coming in soon here as well. You did mention that there are cardio symptoms and ophthalmic symptoms. Do you have a moment to just touch on those, even though we didn't have time to fully investigate those here today?
Yeah, absolutely. So for the ophthalmic symptoms, one of the more common ones is actually lacrimal stenosis. Okay. So patients can complain of dry eyes. It can be very uncomfortable. For cardiovascular, fortunately, these are not common, but they can be more of like a vasospasm of coronary arteries. Okay. But there are also reported myocardial infarctions. Okay. With 5-FU as well. Okay.
Would these be symptoms, again, that we would expect to go away once the medication was discontinued?
Yes. So if patients have chest pain, usually you would not want to start 5-FU again. Because you don't want to initiate an MI.
Well, this has been really fascinating, and I know these side effects that you talk about can be extremely difficult for patients. What is it must be a balancing act for the pharmacist in terms of a patient shows symptoms, backing off or stopping the administration of 5-FU, and then administering again when possible. What does that look like for patients that are experiencing more symptoms in terms of kind of that walking that back and forth with the administration of the medication?
Yeah, it is really a balancing act, and one thing is that what makes it more difficult is when 5-FU is combined with other drugs. Right. One thing I didn't have an opportunity to go into was the regimen FOLFIRI, which is 5-FU given with irinotecan. Okay. So irinotecan also has a high incidence of diarrhea as well. So that is something to consider in how you manage it. Can be you have to take the irinotecan into consideration. So again, it's that balancing act, and you have other drugs that are given with it that are causing similar toxicity.
So it's very challenging, and I'm glad we're discussing this, because I know this can make a tremendous difference in the lives of patients, being able to address these issues. We do have some questions. Can you use uridine for PTS for patients who get 5-FU toxicity who are missing the gene to metabolize the medication?
Yeah, actually, we did not go into DPD deficiency, so this is the major enzyme that metabolizes 5-FU.
Okay.
So a very small percentage of the population is deficient on this enzyme. So actually, for these patients, I don't think it's not been studied using uridine. So so that at this point that wouldn't really be an option. And because the toxicities can be so severe, usually if patients we either give them an extremely small dose or we look for alternative therapy.
Okay. And another great question here, why do women get more toxic from 5-FU than men? Do we know what causes the disparity there?
And I'm sorry, I actually don't know why women have been shown in some studies to have more toxicity, but I think that's a great question.
Okay.
Yeah.
And is the topical 5-FU still used for leukoplakia? Is it plakia?
You know what? I'm not really sure. I know that we use topical 5-FU for some skin cancers, but I will say that's not something I'm very familiar with.
Gotcha.
So can't answer that one.
And do you know, would we expect the same side effects with a topical that we would with the oral or the IV?
We wouldn't, due to the minimal absorption into the system, into the body. Therefore, you wouldn't necessarily expect these toxicities.
Okay. In reference to discontinuing the 5-FU bolus due to toxicity, would an overall dose reduction be just as appropriate?
Yes, you could just do an overall dose reduction as well. Again, you're going to manage that patient also depending on what other chemotherapy agents they're getting. Okay. Can be an appropriate way to manage them.
All right. Well, if anyone else has questions, now's the time to go ahead and submit those to Dr. Faso. This has been fascinating. I really appreciate this. We will have this archived, so anyone may go and view the video. And just a reminder that we now have our lecture set up as enduring materials. So within a year of today's lecture, anyone may come back and watch that video, take a short test, and receive a certification for that, free of charge as well. So we're happy to offer that new service. With that, we want to say thank you to you, Dr. Faso. We're really glad that you're here today. I did want to mention we did talk a little bit about cryotherapy, and we hope to be able to arrange a lecture in the 2018 calendar year to more specifically talk about cryotherapy with alopecia and with reducing symptoms from Taxol for peripheral neuropathy symptoms, etc. So look for that. We'll be releasing the full schedule of all 2018 lectures soon. Thanks to the generous support from the North Carolina General Assembly, of the University Cancer Research Fund, and the UNC Lineberger Comprehensive Cancer Center. Thank you to Mary King, Veneranda Obore, and John Powell for all the hard work that they're doing to make this and every lecture possible. Coming up, we've got January 24th, our MedSurg lecture, Managing Lung Cancer Heterogeneity, and that's with Dr. Jason Kulian. On January 26th, we have Community Lunch and Learn lecture on cancer, Supporting Adolescents and Young Adults Living with Cancer, Practical Tips for Friends, Families, and Communities. That's with Lauren Lux. And on February 7th, our RN and Allied Health lecture, Provider Burnout and Compassion Fatigue in the Clinic, Strategies for Preventing and Mitigating Symptoms, with Dr. Samantha Meltzer-Brody. So we hope that you'll be able to join us for all of those lectures. Please spread the word both about our upcoming lectures and about the availability at unccn.org to view those in our library, along with about 200 other lectures that are there, to go to our learn.unccn.org LMS, Learning Management site, where you can go ahead and watch those past lectures and receive credit for those as well for lectures beginning in November. All right, if you want to be on our newsletter, just go ahead and send us an email, unccn@unc.edu. Let us know. We'll add you to our newsletter list that comes out on a monthly basis. We're on Facebook, we're on Twitter, we're on YouTube. We hope you'll find us wherever is most convenient. And Dr. Faso, thank you again for being here. We really appreciate it.
It was a pleasure. Thank you.
Thank you.